Blackburn.
My lady, may I call the next witnesses, please? Professor Claire Herrick and Professor Azim Majid.
If you could repeat after me, please. I do solemnly,
I do solemnly,
sincerely and truly
sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Please. If you could repeat after me, please. I do solemnly,
I do solemnly,
sincerely and truly
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you, please.
Thank you for coming along to help us.
Professor Herrick, you should have in front of you a copy of your witness statement, which for our reference is INQ 000661715. Can you confirm, please, that that is your witness statement that you've provided for the purposes of the inquiry?
It is.
Thank you. And that the facts stated in it are true to the best of your knowledge and belief?
Yep, they are.
Thank you very much. Professor Majid, you should also have in front of you your witness statement with our reference INQ 000659865. Can you confirm that that is the witness statement you've provided for the purposes of the inquiry?
Yes, I confirm that.
Thank you. And that the facts stated within it are true to the best of your knowledge and belief?
Yes, I also confirm that as well.
Thank you very much. By way of introduction then, Professor Herrick, you are Professor of Geography and Global Health at King's College London, where you have worked as an academic since 2007. Your research concerns the politics of health and healthcare. It spans historical and contemporary issues across different countries. You have researched and written several publications about the UK response to the COVID-19 pandemic. The one that is most applicable to our module is the 2023 paper entitled "We Thank You for Your Sacrifice, Clinical Vulnerability, Shielding and Biosociality in the UK COVID-19 Response." Thank you. And although you confirm within your witness statement that you haven't, since you have completed that paper, conducted any further research, are you happy to confirm that your views are as stated in that paper?
Yes.
Thank you. Professor Majid, you are Professor of Primary Care and Public Health at Imperial College London, where you also serve as Head of the Department of Primary Care and Public Health. For 30 years, you have combined clinical work as a general practitioner with research and teaching. You are a National Institute for Health and Care Research Senior Investigator, and you are Director of the NIHR Applied Research Collaboration North West London, a Fellow of the Academy of Medical Sciences, a Fellow of the Royal College of Physicians, the Royal College of General Practitioners, and the Faculty of Public Health. Is that right?
Yes.
Thank you. I'd like to begin, please, by coming to you, Professor Majid, and asking you about the definitions of clinical vulnerability and clinically extreme vulnerability, or clinically extremely vulnerable. What is your understanding of the definitions that will fall into each of those categories and the differences between them, please?
So these are two groups which do overlap somewhat. So the boundaries are not entirely clear where one ends and the other one starts. So
Yes.
the first group, clinically vulnerable, they're people with long-term medical problems like heart disease, diabetes, asthma, which place them at higher risk of complications from infections such as COVID-19.
I'm sorry to interrupt you. Could I ask you to slow down a little
Sorry,
bit,
yeah.
please? No, don't worry. The stenographer needs to pick up what you have to say.
So, as I was saying, the two groups do overlap somewhat, so the boundary is not entirely clear where one ends and one starts.
Yes.
The first group, clinically vulnerable, are people with long-term medical problems like heart disease, diabetes, asthma, that place them at risk of adverse health outcomes from infections such as COVID-19. The second group, the clinically extremely vulnerable, is a smaller group, but with more serious medical problems. For example, people who've undergone organ transplants or with immune deficiency. And so they're at the highest risk of adverse events from any kind of infection.
Thank you. During the pandemic, the UK government identified these groups based, I think, on guidance from bodies such as the National Health Service and Public Health England, and later on also the UK Health Security Agency. And people who fell within those groups were advised to shield from March 2020. Is that right?
Yes, people in the second group, the clinically extremely vulnerable, were advised to screen, to shield. The first group were advised to take just additional precautions, but not to shield. So the bigger group, which was the clinically vulnerable, were not advised to shield, but were advised to take additional precautions to reduce their risk of infection.
Right. Well, we'll come to discuss the definition of shielding as well in a moment. But Professor Herrick, can I ask you about the changes that took place between these categorisations over time? Were they solid in terms of people who would fit into each category, or was there a certain fluidity about them?
There was certainly a certain fluidity for both the categories. So the people that were included in the categories changed over time. Delineation of the categories changed over time. And people were added to categories, most notably in February 2021 when a new risk prediction algorithm was brought in that added, I think, over 1 million people. And people also taken away, just very suddenly by text message, just one day to the next, text message to say that they were no longer categorised as clinically vulnerable based on the course of COVID at that time.
Yes. So is it right that because of all those changes and the unpredictability of them, people were finding the position confused and confusing?
Yeah, absolutely. Especially when people felt that they should be included by virtue of their own understanding of their personal health conditions and yet were not included, which meant people coming back to GPs to then ask to be included in a list.
Thank you.
Sorry to interrupt. Can I ask you, I maybe ask you to play devil's advocate here,
Sure.
Professor. If you change a category depending on the course of COVID at the time, surely your categorisation would remain the same, whatever COVID was up to, or do you mean the knowledge of how COVID was transmitted? Or
the two categories had the same name, clinically vulnerable and clinically extremely vulnerable, the people that were contained within them and the conditions that delineated who would be in it changed over time. So people's understanding of what they were at that time may not have caught up with what the category itself was composed of, if that makes sense. If someone tells you...
I'm sorry, what I'm asking about is the change and how, depending on the course of COVID, you said, people thought it was a good idea to change their category. So in other words, if I was clinically vulnerable in September 20,
Yeah.
why am I not still clinically vulnerable in February 21? Or
Well, that's a good question. I think.
That's
Why
I'm
were
asking
you
to
not
play
suddenly?
devil's advocate.
Yeah, I mean that's a very good question. Why were you suddenly not clinically vulnerable? And certainly those changes in categories did not chime with people's own understandings of their own vulnerability. So to be told that you're vulnerable and then suddenly, oh, you're not vulnerable anymore, for people individually, that must have been exceptionally confusing and made very little sense.
Thank you. Going back to the beginning of the pandemic, you tell us at paragraph 2.4 that in the Prime Minister's national address on the 16th of March of 2020, that was the first moment that the population was instructed to shield those that had, and I'm using his words, the most serious health conditions. But it wasn't for a couple of days until the interim list of clinical conditions was finalised to denote the membership of the clinically extremely vulnerable category. And that definition at that time was to remain in place until summer of 2020. Age was not included as a criterion, was it, in the CEV category?
No, it wasn't expressly included as a criteria, but to my understanding, 2/3 of people included in that category were over 65.
Right. And those aged 70 and over were advised to take extra precautions, weren't
As
they?
part of the clinically vulnerable
Yes.
category. Yeah.
Yeah. Okay. So in theory, that list would have aligned with NHS records. Is that right?
As far as I'm aware.
Yes. And we know from evidence that we're going to receive in the inquiry tomorrow from Professors Watson and Shakespeare that people were informed by letter from their GP or other health provider whether they were included on the list. And they confirm also, as I'm sure they will tell my lady tomorrow, that those groups were amended and changed over the course of time, which chimes with what you've just told us, Professor Herrick. But by May 2020, an estimated 2.2 million people were classified as clinically vulnerable, which you say at paragraph 2.6 was far in excess of the 1.5 million initially estimated to fall within the category. Was the categorisation common across all 4 nations of the United Kingdom? Was there any variance within it, do you know?
That's a good question. The paper that I wrote was based on England. As far as I'm aware, the categorisation remained the same, but the data that was used to identify people was different, given the different data systems that are used. So there would be perhaps different rates of missing people out or including people that shouldn't have been there. So the error rate might well have been higher.
Yes, I understand. I'm going to take you now to your paper, if I may, because as well as whether or not there was a commonality in description across the 4 nations, I want to ask you about what was happening elsewhere in the world, really just to identify and highlight the importance of a definition and what people were being asked to do. So please could we have on screen INQ 000655834. Can you confirm, please, Professor, that this is the article to which I've referred?
Yep.
Thank you very much. And so please can we go to page 2 and to highlight the part of the paragraph that starts with this paper. Thank you. So you explain here, this paper explores how the UK's ever-changing classifications of clinical vulnerability have created a confusing and transient category, not in the sense of afflicting a single person for a while and then going away, but in the sense of existing only at a certain time and place. Let's go then, please, to page 5 and to highlight the passage that begins on March the 12th. Thank you very much. There we are in the middle of the page. And I'm just going to read through these before coming to some questions. Thank you very much. So dealing with the history of matters, on March the 12th, Johnson gave a speech in which he spoke directly to older people. This disease is particularly dangerous for you. Even though for the vast majority this will be a mild to moderate illness, I know that many people will be very worried. We should all be thinking about our elderly relatives, the more vulnerable members of their family, our neighbours, and everything we can do to protect them over the next few months. Then, 3 days later, on March the 15th, the government expanded its public education campaign beyond hand washing to avoiding older and more vulnerable people if exhibiting symptoms. On March the 16th, now with 1,543 official cases, the government held the first of its daily coronavirus briefings, during which the Prime Minister, Chief Medical Advisor and Chief Scientific Advisor announced new social distancing measures, the suspension of mass gatherings, asked symptomatic households to isolate for 14 days, the public to cease all unnecessary contact with others, and halt all non-essential travel. Johnson's speech at the press briefing that same day warned that by this coming weekend, it will be necessary to ensure that those with the most serious health conditions are largely shielded from social contact for around 12 weeks. This is going to be very disruptive for people who have such conditions and difficult for them. I know that many people, including millions of fit and active people over 70, may feel there is something excessive about these measures. Now, I want to just concentrate on the word shielded, because in the following paragraph we see this. The linguistic fusion of vulnerability with shielding a term not previously used in the lexicon of public health responses to infectious disease, quickly become one of the defining narrative strategies of the UK government's approach to risk reduction. The implications of this are then further explored. So the word shielding and shielded, that phrase hadn't been used before. That was something new in the pandemic. And did that in itself cause confusion as to what that might mean?
Yeah, I mean, absolutely. If you introduce a new word to the public that means that they have to adhere to really stringent sets of behavioural guidelines, it's going to cause confusion and worry and concern. But I do think that shielding took hold among the public more quickly than vulnerability, because vulnerability was more confusing. Shielding, there was a lot of work that went on for the messaging around shielding.
Yes.
Behavioural Insights team, government, NHSX, especially around text messaging, to convey what shielding was and what it meant. And because it's linked to a set of actions and things to be done, it was much easier for people to understand what it meant, whereas to be vulnerable is very confusing to people about what should they then do.
Yes. So there was something directive, but something that was easily understandable around the word shield and the term shielding.
Yeah, because I think it connoted a series of actions that needed to be taken by both the person shielding and also people that needed to shield them. That was very clearly communicated.
Thank you. Let's turn to page 14 of your article, please, and have a look at the meaning of the word in terms of what it conveyed. You say here, given the overtures of protection, duty and weakness bound into the word shield, it serves to convey a sense of vulnerability far better than isolation. However, beyond this, its use as both a technical term and a moralised political trope is deeply significant, particularly in its creation of a new category and thus subjectivity of shielders. And at the bottom of this paragraph, you say, as a letter to the British Medical Journal notes, the UK shielding policy is unique internationally, even if it was arguably far from unique in its effectiveness. What did you mean by its uniqueness?
No other country used the word. I mean, when I was writing this, I searched desperately for some other example where this word might have been used. And it wasn't used in any other country it's not used in any other context when it comes to public health.
Right, thank you. I just finally on this point want to look at an expansion of that in the following paragraph, where you say in the US, for example, CDC, what does CDC?
Centres for Disease Control.
Thank you. Guidance recognises people at increased risk of severe illness and those who need extra precautions. Australian guidance singles out those at higher risk of severe disease. The World Health Organization identifies those over 60 and those with underlying medical conditions as being at higher risk of getting severe COVID-19 disease. By contrast, it defines vulnerable population groups as those who are socially vulnerable by virtue of being homeless, migrants, refugees, disabled, living in remote locations or closed facilities, or being in poverty. The French response categorises personnes fragiles as those at risk of severe COVID-19 illness. And similarly, the Swiss classify those at higher risk as personnes vulnérables. Finally, the European Centre for Disease Prevention and Control makes a distinction between those people at higher risk of severe disease, high-risk groups who are medically vulnerable, which is counterposed against those populations who are socially vulnerable to the consequences of the public health measures that have been imposed to control the spread of the virus and which may exacerbate their already changing life situations. So, across the world, lots of variation.
Yeah, absolutely, which I think just points to the complexity of dealing with the situation at that time and thinking about how do you link actions to categories of people in ways that are meaningful and in ways that people can adhere to.
And I suppose a demonstration of the complication that can arise by different phrases being used in different parts of the world.
yeah, you know, there's a lot of complexity in just the difference between risk and vulnerability, how you define vulnerability, how you define risk. Is it medical? Is it social? And all of those things come together to mean different words are used in different contexts, and also different medical traditions may favour different words in certain
Yes.
contexts. But that said, still, I think the UK was unique in using a word that is not used otherwise in public health.
Yes.
Whereas in other countries, it was very much within the lexicon of public health. So
Right.
an already familiar language was used.
And is there any prospect of there being a common phraseology used across the world, do you think?
I mean, public health is very particular to
Yes.
each country, so probably not, although I think the examples that I list there are probably more similar than the UK.
Yes, thank you. Professor Majid, I'd like to come to you now, please, to discuss data collection, which you deal with in your report. Tell us, please, about overlaps in data collection and the challenge of separating data in order for it to be used to its optimum potential.
So the NHS has good medical records, you know, in electronic format, but they've been quite fragmented in different systems. So hospitals, GPs, etc., have their own systems. So when the pandemic occurred, there was a need to integrate those records into a unified whole, and that was done fairly quickly. And so we were able to link records from GPs with hospitals and elsewhere to provide data to monitor the impact of the pandemic, to identify people who were clinically vulnerable, and to look at health outcomes as well. So that was an essential task. You could argue it could have been done before the pandemic and should have been in place before, but it wasn't in place. But to give credit to the NHS, it was done very quickly and was a very useful resource once that work was done.
Thank you. I'm going to use a phrase now, the National Data Platform. Is there a suggestion that the creation of such a platform would bring together general practice records, hospital data, social care data in a unified, privacy-protected place, so that keeping all of that data in one place and allowing it to be accessed by those who need to, it would improve the quality of the data and would simplify the collection of it?
It would definitely simplify the process because we don't need to link data from different systems. That work would have been done through this new system. So it would definitely simplify the process of data analysis and data interpretation.
Do you consider that the lack of routine disaggregation by clinical vulnerability status in health data has limited the ability to understand outcomes and inequalities?
So we know with medical records, there are errors in all medical records. You get what we call false positives, where a diagnosis is present, where actually the patient hasn't got that diagnosis, and false negatives, where a patient has a diagnosis but no one's recorded it on their record. So there are clearly errors, and by having data aggregated, you can look in more detail, you know, by hospital or by general practice, at data quality and feedback that information to try to improve data quality. Because data quality is a key, you know, the key factor which makes these data useful. With poor quality data and lots of errors and omissions, the data will miss certain people or put people in the category incorrectly. So data accuracy and quality is a key requisite for any system for addressing health crises like a pandemic.
And what evidence or data do you consider would best capture the impacts felt by clinically vulnerable individuals or their families in this regard?
So all record systems have their own strengths.
Yes.
The most comprehensive is GP record because that has most of the information on it. But it is lacking information on drugs, for example, prescribed by specialists or
Yes.
by rare diagnoses. So you need to combine both to get the maximum value. But in general, the record held by the GP has the most data, but will miss certain attributes like specialist drugs, which are not prescribed by GPs.
Moving on slightly to talk about the nature and quality of research and evidence, including potential shortcomings. You tell us in your statement about the INFORM study that took place during the Omicron era. Tell us what that entailed and what the results showed, please.
So the INFORM study used data from the system you just described, the National Data Repository.
Yes.
It used data on about a quarter population of England and looked at outcomes in people who were classed as clinically extremely vulnerable compared to the general population.
Could I ask you to slow down
okay.
again, please? Thank you.
What it showed was that people who were clinically extremely vulnerable had a much higher risk of adverse events like hospital admission or death than people in the general population. And that increased risk persisted despite vaccination. So all the vaccination did suppress risk in all groups. Groups who were clinically vulnerable still had a higher risk of adverse health outcomes like admission to hospital or death. So vaccination does help, but by itself it's not enough to suppress the risk down to the level of the baseline population.
You tell us that ethnic minority data was poor.
So there was often a lack of data on ethnicity in medical records. The NHS has tried for a long time to improve that data quality. I think it has improved since the pandemic because the pandemic exposed the need for such data. So we have seen improvements, but at the start there were certainly deficits in data, and many people did not have their ethnic group recorded in their NHS medical record.
But at a high level, the INFORM study found that immunocompromised people were up to 13 times more likely to experience serious outcomes such as hospitalisation, intensive care unit admission or death, even after vaccination.
That's correct, yeah, depending on your clinical category. So the risk
Yes.
was highest for those who had organ transplants, for example.
Right. Yes, thank you. Turning to the second area, please, that I'd like to ask you about, the impact of the pandemic on clinically vulnerable and clinically extremely vulnerable groups. Professor Majid, do you agree that the pandemic and its control measures didn't affect all groups equally, and that for clinically vulnerable and clinically extremely vulnerable people, they often exacerbated existing health risks and conditions, resulting in a distinct health inequality?
Yes, that's definitely the case, particularly when there was intersection of, say, poverty and clinical factors. There was definitely an excess impact on some groups compared to others.
Yes, the inquiry has heard this morning from Professors Marmot and Bamborough that really one needs to look at the intersectionality between different areas of people's lives, and the picture is particularly complicated, or can be particularly complicated, where there are lots of overlap of vulnerabilities and disabilities and issues such as socioeconomic deprivation, that sort of thing. It's not necessarily a clear picture, is it?
No, it's not, no, and it does depend on how these factors come together.
You tell us at paragraph 13 of your statement that several factors mitigated or worsened impacts from infection, and that vaccination was a key mitigator of adverse outcomes.
That's correct, yes. The vaccination did reduce adverse outcomes for all population groups if they were fully vaccinated.
Thank you. Although you go on at paragraph 19 to tell us that later in the pandemic, clinically extremely vulnerable patients sometimes reported difficulties in obtaining antiviral drugs after testing positive for COVID-19.
Yes, that is the case because there were variations across the country in access, what you might call a postcode lottery. So in some areas it worked better than other areas, and I think we can learn lessons from those areas where the system performed better than others.
Yes, thank you. And you go on to say that previously people would have been contacted by their local COVID-19 medicines delivery unit once they logged a positive COVID-19 test. But then the system changed, and in the new system, the onus was now on patients to contact their local health services when they had a positive test, and that caused confusion.
Yeah, that's correct. So the system changed, and clearly people who are less well educated or with poor English will struggle with that new system.
Thank you. Professor Herrick, I'd like to ask you about a change in direction or guidance that was given by the government from a rule-based system to something called personal responsibility, and how that affected those who were both clinically vulnerable and clinically extremely vulnerable.
So when lockdowns were lifted,
Yes.
well, I think some of the tensions here is that public health guidance is generally based on personal responsibility.
Yes.
Because the UK, the predominant diseases are chronic, most of public health advice is about behavioural risk and self-responsibility and modifying behavioural risk. Obviously, when you have a novel infectious disease, the way that risk is managed is completely different and largely unfamiliar to people in the UK. But when restrictions were lifted, suddenly that idea of protecting others shifted, and it became an advice to people who had previously been shielding. And at this point, when those restrictions were lifted, still a huge proportion of people who had initially been advised to shield were continuing to do so.
Yes.
To kind of reintegrate themselves into society, to, if they could go back to work, they should go back to work, or if their workplace was COVID safe, they should go back to work. And obviously for people that have been isolated at home, this is a moment of deep confusion about what is actually safe. And I think the moment of those restrictions lifting also chimed with a sort of moment of a fraying of trust in the government response. And so I think that made things much less clear for people. So rules are easy to follow, but suddenly when there are no rules, it's very hard to make personal risk calculations.
In your view, were there inequalities created by this change of system?
I think certainly, yes, in some respects, but possibly no greater than existed before, in the sense that if you were able to work from home, people, you could continue your daily life without fear, without risk. For people that couldn't work at home,
Yeah.
Then you start to get into this sort of set of impossible risk calculations, and especially if your workplace couldn't be made COVID safe, as it was called at the time, what do you do?
Yes.
Do you put yourself at risk, having previously been unable to leave your house? Or do you decide that actually the risk isn't worth it? And some of the data bears out that people made that active decision to say, actually, I'm going to have to leave my job because it's not safe.
What, in your view, what changes are needed or can be considered so that high-risk groups are not left to manage their harm individually?
I think it would be a very difficult one to say. COVID was exceptional. It won't be the last time that there is a novel emerging infectious disease, but it's very hard to generalise from something so specific. If there is another pandemic, the clinically vulnerable groups may be completely different. It may be children.
Yes.
Who knows? So it would be impossible to generalise about what could be done differently in this sense. It was what it was, based on who was categorised as risky and vulnerable at the time.
Yeah. Thank you. I'd like to now move to talk about the impact of shielding. And could we display, please, INQ 000661715, which is your witness statement, Professor Herrick, and go to page 4 and display paragraph 3.2. Thank you. By February 2021, you tell us 3.7 million would be classified as clinically extremely vulnerable, which was a gross increase on the 2.2 million classified as such in 2020, which was the previous figure that we discussed. This increase was fuelled by the inclusion of some disabilities, for example, Down syndrome, as a marker of CEV, and the introduction of a new risk prediction algorithm in February 2021. This tool identified an additional 1.7 million people as clinically extremely vulnerable, as it included deprivation scores, age, ethnicity, and domicile type as indicators of risk. This shift also then included women with a history of gestational diabetes, but not those with current diabetes. So I want to just pause for a moment and ask about the characterisation of Down syndrome as a basis for clinically extremely vulnerable designation. Was that included, do you think, because there was an increased risk caused by an array of health issues such as immunological issues, congenital heart and respiratory conditions, and increased rates of obesity and diabetes?
Yeah, that would be my understanding.
Thank you. Linguistic slippage is another phrase which is used. Linguistic slippage, paragraph 2.10, we don't need to display this, but between guidance and advice, and the confusion between CEV and CV people led many, you say, to shield unnecessarily. So can you explain, please, what you mean by linguistic slippage between guidance and advice?
I mean, guidance and advice have different meanings, but were used interchangeably, often in the same sentence, advising people. This guidance is advisory, but we strongly suggest that you follow this advice.
Yes.
I mean, how anyone is supposed to decipher this and decide what they should do, especially against the background, at the time, 2020, 2021, it was all about the rules. This is the COVID rule. 2 meters away from someone, don't do this, don't do that. And so you've got a background of the rules against sort of patchwork of lockdowns, and then people being guided and advised. Who knows what they should be doing? I think the simplest messaging really was, you're shielding, you must stay at home for 12 weeks. That's something that somebody can understand.
Something solid.
Solid,
yes.
Very hard to do, but very solid, and I think that was the point of it. But the rest, especially in the letters that were sent to people, very hard to know, am I going to be arrested if I step outside my home? What if I open my window? Can I go into my garden? And these are all legitimate questions that people had at the time that seem bonkers, really, but when you're being advised and guided, how do you know what you should be doing and where the risks lie in a disease that no one knows anything about?
The inquiry has already begun to hear evidence of the effect of shielding and isolation on people's mental health and how severe that became for some. So in your view, it was important to have as clear a message as possible so that those who really did need to shield understood that was the advice or guidance, whereas those who really didn't need to shield may have been confused or shielding unnecessarily.
Yeah, and I think that messaging was very effective. If you look at the rates of people that were shielding, it's extraordinarily high. I mean, the British love a rule, so I think that it was very effective, but a lot of work went into that messaging in terms of behavioural psychology and how do we get people to adhere to this, and a lot of it was about messaging of altruism, support, you can do this, and encouraging others to support others. So there was a lot of psychology that went into the adherence to that.
And finally on this topic, you describe at paragraph 3.5 the neologism of shielding and entering the mainstream language. You also go on to say that the notion of the clinically vulnerable and clinically extremely vulnerable needing to be shielded, which is the passive rather than the active form of the verb, from risk, is in stark contrast to the general tenor of public health messaging that focuses on individual agency, control and responsibility. And this induced novel forms of health behaviours and beliefs, which in turn often set up new types of intergenerational conflict and solidarity. What do you mean by that?
I mean, I think it was socially a very interesting moment that if you have delineated all people over 70 as clinically vulnerable, you've associated vulnerability with the need to shield, even if technically those who aren't clinically vulnerable don't need to shield.
Yes.
And you've cast shielding in the language of protecting others. There's therefore the assumption that anyone over 70 must be protected by everybody else, and this is our societal duty, which is quite a new way of looking at things. And that therefore sets up the assumption amongst people in particular categories that there is a duty of care, which, I'm not casting judgment whether or not this is right or wrong, but socially that's an interesting thing. So there is an intergenerational difference, I think, in how people viewed what society should do for them, which is very much at odds with the general way that public health goes about things, which is okay, well, stop drinking so much, please don't smoke, don't do this, don't do that, but it's your choice.
Yes.
So I think that is a very novel moment and also a difficult one to exit.
Yes. What further research do you think might be required to develop and implement appropriate public health strategies which protect risk groups going forwards?
I mean, risk groups aren't static.
Yeah.
So these were risk groups for this particular moment in time. Those risk groups have changed over that time, and they won't be the same risk groups going forward. So I think that we can think about language and messaging and categorization and the use of data and the efficiency of that. But again, I don't think you can take general lessons from something that is exceptional. But what you perhaps could look at is the impact of how people view themselves and their own vulnerability, and what long-term consequences has that had for people in terms of how they engage with the world, their workplace, all these things. Has it had an impact on how people see themselves and their own health behaviours going forward?
Yeah. And I suppose as well as thinking about the protection of certain sectors of society in the next public health emergency, there's also the other side of the coin which needs to be considered, which is the potential adverse consequences of telling somebody to do something or advising somebody to do something. And by that I mean, the mental health impact of shielding and isolation.
Yeah, absolutely. But like all risks, it's a cost-benefit analysis. You have to weigh things up. There will be very much adverse effects, but
Yes.
Are they counterposed against, the decreased risk of severe illness and perhaps death if you contracted COVID? Again, in a novel situation, it's very hard to know what the right thing to do is. You just do the best you have given the information available.
Yes.
But yeah, I think going forward, there will always be certain groups who will be much more vulnerable, where care has to be taken appropriately in terms of safeguarding those groups.
Thank you. I'd like us to look now at some of the experiences that the inquiry has heard about during our Every Story Matters campaign. And let's put up, please, I'm just going to give the INQ reference for the record, 000 659 895. Thank you. And can we go to page 33, please? Thank you. So we can see here that this is the experiences of those who shielded or who are clinically vulnerable. People who were advised to shield or who did so to protect clinically vulnerable family members told us how difficult this period was. Shielding often brought deep feelings of isolation, loneliness and anxiety, made harder by the constant worry about catching COVID-19 and the potential impact it could have on loved ones. The experiences of clinically vulnerable people during the pandemic are covered in further detail in modules 3, 4 and 8 and their Every Story Matters records. One Every Story Matters contributor from England said, "I have no spleen due to cancer, so I'm clinically extremely vulnerable, and we were told to shield. This was isolating and difficult and harder for the fact that the rest of my family didn't have to shield and always risked bringing the virus home to me. Mental health has been an issue since, and I'm still worried about travelling, being in buildings near other people, and I feel far more nervous and anxious than before the pandemic." Another contributor told us, "I was in the extremely vulnerable category, so shielded for the first few months of the pandemic. It was a very scary and isolating time, and it affected my relationships with family and friends, some of whom couldn't understand why I was being so cautious. I'm still suffering from a mental health perspective due to the stress and isolation." People who had been shielding spoke about the distress and anxiety they felt when restrictions were lifted. Many described how unsettling it was to mix with others again and how strong their fears remained about catching the virus. Some in clinically vulnerable households told us they stopped working or limited contact with loved ones to protect family members' health. The ongoing isolation and fear took a heavy emotional toll, leaving lasting effects on their mental well-being. Further into the pandemic, when shielding was lifted, I was told to return to work, says an Every Story Matters contributor from Scotland. I was so scared of going back to an indoor space with lots of people, I realised I just had to face the world again. But the anxiety level was extreme. My work went through the motions to show support, but it was clearly causing problems. I was struggling emotionally and physically, and so left in May 2021, and I have never worked since. Thank you. We can take that down now. But it wasn't just the shielding and the isolation and the undoubted mental health effects that had. There were also poorer health outcomes for those who were clinically vulnerable and clinically extremely vulnerable. And sadly, also a heightened risk of death. Is that right, Professor Majid?
That's correct, yes. They remained at high risk of death throughout the pandemic, even post-vaccination.
Thank you. Professors Shakespeare and Watson, from whom we will hear tomorrow, tell us in their report that people who self-identified on the 2011 census as requiring a little or a lot of support represented 60% of all COVID-related deaths in England between the 24th of January and the 20th of November 2020. And they talk about the risk of death for more disabled men being 3.1 times greater as compared to non-disabled men. We've also looked at a briefing by the Health Foundation, which is entitled Assessing the Impact of COVID-19 on the clinically extremely vulnerable population, which tells us that NHS digital data shows that a total of 50,635 clinically extremely vulnerable people died in England between March and August of 2020. Does the higher mortality level of rates amongst the clinically extremely vulnerable population reflect the nature of their health conditions or the pandemic and the effects of the pandemic, or a combination of both? And is it possible to distinguish between the two?
It's a combination of all those factors, so the pandemic, their age, their medical problems, their disabilities, their socioeconomic status, all those would interact to increase their risk.
And so one of the most important protective factors, particularly for these groups of people, was vaccination. You deal with this at paragraph 13 in your statement, Dr. Majid. By how much did the vaccination of these groups of people mitigate the risk of death?
So for people who were fully vaccinated with 3 doses, perhaps 90%, so it was quite a large reduction in their risk of death. But that did vary by clinical group. Some groups showed little benefit from vaccination, but generally it was up to 90% reduction in death rates if you were fully vaccinated.
Thank you. Turning to look at unequal impacts and intersectionality, we've touched upon this already. Did you find, though, Dr. Majid, that disparities were stark?
We did, particularly in the first year of the pandemic, before vaccination was present. So death rates were much higher in the clinically vulnerable and the extremely vulnerable, in ethnic minorities, in those with disabilities, in poorer groups. So certainly in the first year, there were stark disparities. Those did somewhat attenuate over time as vaccination became available and everyone essentially became infected with COVID at some point in their lives. But in the first wave, there were certainly stark disparities in outcomes between different population groups.
And we've also touched upon mental health, but I want to ask some more questions about mental health and well-being across the whole of the pandemic. We know that clinically vulnerable families, who are a core participant in this module, ran a survey in the summer of 2025. In fact, let's have a look at the survey findings that appear in the statement of Lara Wong from Clinically Vulnerable Families at INQ 000657970. We can see that this is her witness statement. And if we go to paragraph 23, which I think is at page 11. Thank you. This is a survey in relation to which they received 125 responses from people in clinically vulnerable households across the United Kingdom, capturing experiences over multiple stages of the pandemic. And we can see that the responses showed that impacts were multi-layered, often combining social, emotional and practical challenges. Participants described both the direct strain of living with increased health risks and the secondary effects of prolonged exclusion from safe public spaces, healthcare, and social contact. And the key themes that emerged from the data included the following. Social isolation was reported as a major factor for most respondents, associated with shielding, ongoing risk from airborne infections, and the withdrawal of mitigations, for example, masking in public and healthcare settings, leaving many finding it harder to return to their former lives. Second, a large proportion described their concerns linked to increased infection risks, particularly in healthcare environments, workplaces, and high population density public spaces without ventilation or masking. Third, many experienced depression and a sense of hopelessness when mitigations were lifted without protections for high-risk individuals. Fourth, grief and trauma were compounded by circumstances such as being unable to visit dying relatives, restricted funerals, or lack of post-bereavement support due to shielding. And 5, reports of loneliness were particularly acute in households not only where the clinically vulnerable and clinically extremely vulnerable individual lived alone, but also where they were the only vulnerable member, creating divisions within families about acceptable risk and behaviours. So the whole gamut of mental health effects upon those who were following the rules and who were trying to protect themselves, often, as we've seen with that final point, in families where they might have been the only vulnerable member. Do you say, Professor Majid, that those difficulties affecting the mental health of clinically vulnerable and clinically extremely vulnerable individuals alleviated as the pandemic began to pass, or do you think that there is an argument for saying that for those people, as life was getting back to normal for the general population, really that they were still stuck in a life of taking these additional precautions for a lot longer and perhaps until today?
Yeah, I think the latter. I think once measures were relaxed, this group still felt very vulnerable and had high levels of anxiety, depression, and still felt concerned about their risk of infection and risk their health if they did get infected. So those feelings did persist once measures were relaxed in 2022.
And is it your view that for some of the people who fall within those categories, that mental health difficulty or the changes to their lives which started during the course of the pandemic are continuing to persist today?
Yes, even now there are people who struggle to cope with the changes that have occurred since the pandemic started and struggle with getting back to normal routines, as was seen in your examples.
Thank you. Finally, I'd like to ask you about lessons learned and what can be considered by way of improvement for the future. We've touched upon data collection, and one of the other issues which you raise, Professor Majid, in your statement is an increase of trust between communities and public health authorities.
Yes, so we did see in the pandemic interventions were taken up not in the same way by different groups, and some groups had a lack of trust in authority. So, for example, some ethnic minority groups didn't have confidence in the government or local authorities, and that did then lead to a lower uptake of key interventions like vaccination or shielding, for example. So trust is very important, and trust takes a long time to build up. It can't be done in a pandemic. You need to start, essentially now and keep working on it constantly.
Yes. And something which will chime very much with the evidence that the inquiry heard this morning from Professors Marmot and Bamborough is a targeting and proactive strategy around the reduction of inequalities.
Yes, so the health service can do so much, but much of health status is determined by non-health factors like housing, employment, income, and so on, which are not under the control of the NHS.
And finally, from your suggested lessons learned, Professor Majid, you say that there should be an increased level of support to the workforce.
Yes, so we mentioned people are vulnerable in this session, but the health workforce also felt very stressed as well at the time. They were obviously seeing patients with COVID, and some have their own medical problems. And so we also need to protect the workforce as well to ensure it's resilient and can manage any future health crisis that might occur in the UK.
Thank you. And Professor Herrick, to identify a couple of the lessons learned from your statement, you say that there should be greater public understanding of the terms and the issues which a pandemic can throw up onto people who are clinically vulnerable and extremely vulnerable.
Yeah, I mean, I think our understanding of public health terms is probably much better than it was in 2019. I think we're all very familiar with key terms in epidemiology by now, but going forward, I think a simplification of language, not creating multiple categories to describe similar things and shifting them around would be helpful to people.
And you also promote a further exploration and understanding of longer-term effects.
Yeah, I mean, I think that the examples that you put out, your lived experience examples, show that there's a very long tail to this in terms of people's place in the world, and there are very, very different experiences of what happened in 2020, 2021, 2022, and understanding the consequences of that set against the need to protect. So was shielding worth it? Was it worth it in terms of the consequences that many people now feel? Yes, maybe it was in terms of the lives saved. It's hard to quantify what would have happened otherwise. But there has certainly been a long tail in terms of, people's well-being, I think, from this and the way that it was managed.
Thank you very much. Professor Majid, Professor Herrick, thank you for your time. There will be some additional questions, my lady. I hope that you have the list.
I do, thank you.
Can see that.
And we start with Mr. Weatherby, he's just there.
Thank you very much. Very briefly from me, I asked questions on behalf of the COVID bereaved Families for Justice UK group. Professor Majid, you were briefly asked some questions about the Unified Privacy Protected National Data Platform. And this is a concept that in your report you argue for with respect to the need for integrated real-time data linking primary care, hospitals and public health. Can you just help us on what progress, if any, has been made towards that end since the pandemic?
Progress has carried on, albeit not as fast as we might have hoped. There are legal rules around data linkage, which were relaxed in the pandemic, which are now back in force. So those have to be addressed by the government. So I would say that we need to address those legal issues, get public consent and trust, because the public need to be fully on board with the process because it's their data ultimately. But that resource is essential because it allows us to identify risk groups and monitor outcomes and plan interventions going forward for this or any future health issue that may occur.
Okay, can I take it from the fact that there's still questions over the legality of the data issues, that in fact is not in place yet.
Yes, so in the pandemic, as I mentioned, the rules were relaxed
Yes.
somewhat, but those rules have come back now.
Right.
But the NHS is working towards trusted environments where data is anonymised and can be used
Yes.
for...
So would it be of
uses.
assistance if the inquiry were to recommend that that is looked at carefully and
Yeah, I think-
expedited?
I would fully agree with that. We look at
Yes.
that very carefully so that legal issues are not a problem for any future health crisis that may occur.
Yes, thank you very much. And Professor Herrick, you may have dealt with this already, but just for completeness, really, in terms of shielding, are you aware of any post-pandemic research on its use as a public health concept or disease mitigation strategy, other than the work yourself that you've referred to? Is there anything else that we can point to?
Not that I've found
Yes.
in terms of preparing for today to see what
Yes.
else had been written. I couldn't find.
And again, is
very
there a
much.
need for that in terms of it being a new concept and neologism, as you term it?
Yes, I think yes, although it doesn't exist anymore.
Yes.
In a way. So the difficulty is
Yeah.
going back and tracing what it was. That's the methodological problem with understanding
Right.
what shielding was, where it came from, who came up with the term, why
Yes.
they did. So I think it would be more interesting to understand the consequences of
Yes.
that experience on people. So how, in terms of mental health outcomes, physical health outcomes, that would be very important and interesting
Yes.
research to do.
Thank you very much.
Thank you, Mr. Weatherby. Mr. Wagner, who's down opposite to you.
Good afternoon, professors. My name is Adam Wagner and I act for Clinically Vulnerable Families. First of all, a question for Professor Herrick. You say at paragraph 3.5 of your statement that, I'll just let you get to that public support for shielding arguably weakened from June 2020 onwards. Is that proposition based on any particular studies or evidence?
Sorry, paragraph
3.5.
3.5. Sorry, can you repeat the question?
So about halfway down that paragraph, you say, from after June 2020, the public sense of moral obligation and duty to protect the vulnerable arguably weakened. That's the full statement. Is that based on evidence, or is that something that you're sort of taking from general?
I mean, I think that's the general backdrop of what was going on at that time, in the sense that in June, as far as I recall, digging back into my memory, things were starting to open up again. That was the end of the lockdown.
Right, but it's not based on a study or
It's not necessarily
behavioural.
based on study, but it would have been based when I wrote the paper on media analysis of what was being reported at that time in terms of what was going on, what was being said, what were politicians saying. It was a time of a lot of press conferences.
I just want to ask next Professor Majid, please, about data collection. And you say at paragraph 9 of your statement, however, in areas like data collection, overlaps between these two groups, that's clinically vulnerable and clinically extremely vulnerable, made separation challenging, as NHS electronic health records did not always flag clinically vulnerable and CEV, clinically extremely vulnerable status, consistently. Have you got that there? I'm not reading from something you can't see. Do you agree in that respect that a clear, nationally consistent way to define and record clinical vulnerability using, for example, data sets like flu vaccine eligibility would allow protections and communications to be activated quickly and consistently in a future emergency?
I think it would be helpful. So in the pandemic, we saw that these groups were revised at several points during the pandemic. So in general, as the data got better, they were expanded somewhat as you got more data. So I think it would be, ideally you would have these groups categorised in advance of any future health crisis, with the caveat that for each different crisis, they may differ. So for the measles, currently it's children, for example, who are at risk, not older people. So it would vary, for example, on the actual health crisis. But in general, it would be helpful to have the groups defined in advance so that on day one you can press a button and go with any intervention you want to run for those groups.
And I see Professor Herrick nodding there in agreement. And Chair, may I just ask a follow-up question to something that Professor Herrick said about that earlier?
You may.
Professor Herrick, you said entirely fairly that clinically vulnerable groups in the next pandemic may not be the same as it could be, something that affects children or whatever it would be. And you went on to say that it's not necessarily possible to draw general lessons from the very specific situation of COVID-19 and the pandemic that arose from that. May I just explore that with you quickly? Might it be possible to draw some general lessons in relation to groups, for example, immunocompromised people who generally will be clinically vulnerable to lots of different pathogens and probably to whatever pandemic comes next? Might it be possible to draw some, with the caveat that there'll be differences around the edges, that there might be groups that are generally clinically vulnerable in the sense that we now understand it to mean, not just COVID, but to other pathogens? And you might draw a lesson, for example, relating to the workplace where you'd have better air quality as a requirement, some things like that that can apply to peacetime and not just pandemic time, if I put it like that.
Yeah, I mean, there are certainly groups that are clinically vulnerable regardless of what is going on, that cancer treatment, immunocompromised, suppressed, organ transplant, those people are always vulnerable to wherever they are and whatever conditions are being faced, and always have to be very careful. To link that then to the workplace is a question of employment law that I'm not qualified perhaps to comment on. Obviously, we would all like to have cleaner air, and we should all have access to cleaner air. So yes, I would in theory agree with that. In practice, whether or not that can be delivered within every environment is a different question.
Yeah, it would require a variety of expertise in addition to your own.
Yeah, exactly.
Yeah. Just staying with you, Professor Herrick, you refer in your statement of paragraph 2.5 to the categorisation of CEV, clinically extremely vulnerable people, who would be on the shielding list at the time in 2020 when the list began. And this system whereby GPs could categorise somebody if they asked them to, if they, for example, had been missed off, as many people were, the algorithm that used medical records. Would you agree that the actual way the system worked was not that someone self-declared, it was that they would go to the GP and ask to be declared as clinically extremely vulnerable and then have access to the protections if the GP agreed?
Yes. I mean, it depends how you're defining self-declared. I mean, declared themselves to the GP.
Yeah.
Yes. But there were also people that decided to shield even if they weren't actually on that list. Yeah. So there are plenty of people that decided to shield because of their own personal risk calculation. Yeah. But yeah, people were omitted from a letter. There were later communications and broader understandings of what it was, how vulnerability was defined at that point, and then people would say, understand, I think that I would fall in that category, and therefore what do I need to do to have the letter, which became the passport, to the things that you needed to support yourself while shielding.
Yeah, and that's the difference, is that you could self-declare if you weren't on the list, but you didn't have the passports to the benefits that would allow you to do it until it was confirmed by the GP.
Yeah.
Okay, thank you.
Thank you, Mr. Wagner. That completes the questions we have for you, Professors. Thank you both very much indeed for your witness statements. So don't worry if you've something you wanted to say but you didn't quite, but it's in your witness statement. I take the written material into account as well. So thank you very much for what you've said in your witness statements and for coming along today to help us. I'm really grateful to you.
Thank you.
We'll now take a break, I think, before the next witness, and
Thank you, my
I shall
lady.
return at 3:10.
All right.
This one.
My lady, may I call the next witness, Professor Jayati Dashmunshi?
Repeat after me, please. I do solemnly,
I do solemnly,
sincerely and truly
sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the
and nothing but the truth.
truth. Thank you, please.
Professor, I hope you were warned. You were the last witness of the day, so I
Yes.
hope I haven't kept you waiting.
Professor, could you give us your full name, please?
It's Jayati Dashmunshi.
Thank you. And Professor, you should have in front of you a copy of a report with the reference INQ 000588210. Can you confirm that is an expert report that you have provided for the purposes of the inquiry?
Yes.
And can you confirm that any facts stated within the report are true to the best of your knowledge and belief?
Yes, I can.
And can you also confirm that any opinions that you have stated in the report represent your true and complete professional opinions?
Yes.
Thank you. Professor, I'm going to go through your report largely in the order in which you present your conclusions. There is also going to be a few slides that will go up on the screen in front of you. I'll give the paragraph numbers, sometimes touching on things that come up later or earlier. If you need a moment to refresh your memory, please just take the time you need. Thank you. Turning to page 4 first of your report and your professional background. In summary, you are a Professor of Social and Psychiatric Epidemiology at King's College London.
Yes.
And you're also an honorary consultant psychiatrist with the South London and Maudsley Trust and the St Christopher's Hospice UK.
Yes.
And your clinical work covers psychiatry of general adult and older adult populations in liaison psychiatry setting.
Yes.
And finally, you have also researched and published extensively on health inequalities impacting people with severe mental health problems.
Yes.
Thank you. Now, Professor, at paragraph 1 of your report, you touch on the instructions that you received from the inquiry to provide a report on the impact of the COVID-19 pandemic on people living with severe mental conditions.
Yes.
And in your report, you cover 2 elements of that impact. Is it right to say, first, it's the impact on physical health and mortality?
Yep.
And second, the impact on the mental health symptoms experienced by those with the conditions.
Yes.
And I understand that you've drawn on your own research as well as those of others, including some international research.
Yes.
And you also acknowledge the contribution of Dr. Dario Moreno Agostino.
Yes.
It's correct that he conducted research on population mental health trends and trajectories over time, including during the COVID-19 pandemic.
Yes.
Thank you. Moving to the substance of your report, I want to touch first on how you've defined severe mental illness. And it will be helpful to have up on the screen what you've set out at paragraph 17.1, which starts on page 8 of the report. It's inquiry number INQ 000588210, and it's at page 8, paragraph 17.1. And you've set out there a number of illnesses and disorders, schizophrenia spectrum and delusional disorders, mood affective disorders, including severe depression and bipolar affective disorder, neuroses, including phobias, panic and obsessive compulsive disorder, behavioural disorders, including eating and stress disorders, and finally, personality disorders. The last, I think, is the only one where you've not given an example. Could you give an example of a personality disorder?
So personality disorders are essentially long-standing, ingrained ways in which people relate to others, and personality disorders can have an adverse impact on people's relationships and their functioning. And there are many types of personality disorders, such as borderline personality disorder, narcissistic personality disorder, and so on.
Thank you, Professor. Now, turning to paragraph 17.2, which is, again, the same INC number, INQ 000588210 at page 9. What you touch on there is that some definitions of of these conditions also consider a second element relating to the level of functional impairment. And you've said there that this aspect is somewhat fuzzy, and I understand that's because, as well as severe mental disorders, it seems that these criteria also include some common mental disorders such as depression and anxiety. Is that correct?
Yes, that's correct.
Later in your report, I don't need to take you to it just now, but it's at paragraph 21. You say that common mental disorders tend to exist along a continuum. Could you briefly describe what you mean by that?
So common mental disorders are distinguished from severe mental illnesses as being highly common, as the name suggests, in the population, and include conditions like depression and anxiety. So in the population, people may have symptoms of depression and anxiety which exist as a sort of continuum, as a spectrum, with people with more symptoms potentially being more impacted in terms of their functioning, needing to seek care and so on. So I suppose the point I was making is that depression can be more common and less severe, or can also be more severe and therefore included within the purposes of this report.
And some people can experience symptoms across a continuum, so some mild, some severe, so that it isn't necessarily the case you can say they have a disorder or not. It's not a tick box exercise, and you can have some common aspects and some more severe aspects.
Yes, exactly.
So just again, in terms of your approach to that fuzziness, as I understand it, where there's a lack of evidence relating to severe illness, you have included some studies that consider both severe and less severe conditions in your research.
Yeah, I think it's fair to say that the risk factors for mental disorders, whether it's a sort of milder form of depression or a more severe depression, are going to still be similar. So where there was an absence of evidence for severe mental illnesses, I may have looked at the evidence for common mental disorders.
Thank you. And just coming back finally to personality disorders again, it's right to say that some definitions of severe mental illness don't include those conditions.
Yes.
But again, you've included those for the purposes of your report because specifically that group is known to experience markedly adverse impacts, including on physical health and mortality.
Yes.
Thank you. Professor, I now want to ask you just a few questions about the quality of the evidence generally that you've considered and draw out a few points from paragraphs 23 to 26 of your report, which starts on page 10. Now, you've said that ideally you would have data collected on the same individuals over a period of time, which is known as longitudinal data. So would I be right to say it would be quite helpful to have information about the same individuals both before and after the pandemic?
Yes.
But you've said that people with severe mental illnesses can be unrepresented in studies of that type.
Yes, that's true.
Is one of the issues there that the effect of the illnesses themselves makes it quite difficult to recruit and retain individuals in the studies?
That can be a concern, but I think the other element is that the population level cohorts or longitudinal studies might include people with severe mental illnesses, but because they're less common, they're not represented in these data sources to a sufficient extent where it's possible to look at at the sort of size and scale needed.
Draw solid conclusions from that sort of data. Thank you. You also describe cross-sectional data, and that captures data on a number of individuals at a single point. So what you've said is it's useful as a snapshot in time of what those people are experiencing at that point.
Yes.
And so for our purposes, looking at a group of individuals with severe mental illnesses and considering the data at a certain point after the pandemic started.
Yes.
Thank you. A couple more points on limitations. You've pointed out that the symptoms of severe mental illnesses are usually assessed through questionnaires. And is it right that the quality of those can vary?
Yes.
And you also say, and we heard from Professor Osborne about this a little this morning, that some of the studies and research may not be generalisable beyond the participants who took part. What do you mean by that?
So what that means is that the study sample might be from one region, for example, and it might be difficult to then generalise to other regions. So it becomes difficult to make inferences that might apply to another context.
Thank you. We will return later to the issue of particular data gaps, but as a general point, despite these limitations, Professor, it's right to say you have managed to reach some conclusions on the way people with severe mental illnesses were impacted by the pandemic.
Yes.
We'll consider those findings now. Professor, I want to turn to the first point in your report, the first section, that's on excess mortality. That's addressed at section 3 of the report, starting at page 12. The first really important point that you make at paragraph 29 is something I understand is extremely well known in your field, but may not be more widely known, and that is that people with severe mental illnesses are known to have a significantly reduced life expectancy of up to 15 to 20 years compared to the general population. Is that correct?
Yes, that's correct.
And that is across the UK?
Yes.
And also internationally?
Yes.
Now, Professor, you've noted in your report an increased risk of suicide amongst these groups, but it's right to say that that's not an explanation of the reduced life expectancy when you look at the causes of death. Can you expand on that?
Yes, we've known actually for decades prior to the pandemic this very large 15 to 20 year gap in life expectancy. But most causes of death are from common preventable conditions like cardiovascular disease, type 2 diabetes and so on. So although death by suicide is more common in this group, actually most causes of death are through common preventable conditions.
Thank you. You've mentioned in your report, you deal with this in a lot of detail, a number of factors at play. I'm going to ask you a couple of questions about what I understand to be the main ones, and I've drawn conclusions about that from what you've highlighted in your executive summary at paragraph 4. First, the direct effects of the condition itself, including an inability to self-manage physical health and health seek. Could you expand a little on what that last term means?
So health seek refers to the ability to seek care when somebody needs it. And as I've highlighted in the report, the symptoms of the condition might have an impact, but also stigma may also play a role in terms of people feeling that they are unable to health seek when they might need to.
I'm going to come back to stigma in all its forms in a moment. Just before I do that, there's another factor that you've highlighted again in your summary, and I summarise that as a higher risk of health-related behaviours. So could you summarise the sorts of behaviours we might be looking at here which might impact mortality?
So we know that certain health-related behaviours like tobacco use or alcohol and substance use disorders are more prevalent in people with severe mental health conditions.
And finally, mental health stigma. I will deal with this in a little bit more detail. And you say, this is picking up from around paragraph 32 of your report, that this operates at 3 levels. The first is the level of health systems, and you note long-standing concerns about funding for mental health services and a lack of parity of esteem. Could you explain a little more about that term?
So parity of esteem simply refers to the fact that, we would want good parity of esteem for mental health to be given the same status as physical health, and a lack of parity of esteem implies that mental health is given a lower status compared to physical health. And as I've detailed in the report, this then plays out at a health systems level, for example, through lower funding for mental health services compared to physical health services that then have an impact in terms of the quality of care that people with mental health problems might be able to receive.
A related point which you touch on at paragraph 33 of your report is what you describe as siloed care delivery. As I understand it, that's the problem that could arise where you've got physical health care being delivered by mental health providers or vice versa. So can that create the problem of someone who's got a preventable physical health condition but they're falling between 2 stools?
Yes, exactly.
The next way in which you describe stigma is operating at an individual level, and you've referred to diagnostic overshadowing and self-stigma, and Professor Osborne also referred to those sorts of issues this morning. Can you briefly explain those terms and how it could impact on mortality?
So diagnostic overshadowing refers to the situation where somebody with a mental health condition presents for a physical health problem but the clinician attributes the symptoms to the mental health condition rather than the actual underlying physical health condition. So what that then means is that that person is unable to access evidence-based care, good quality care for their physical health need. And there is evidence widely reported in the literature that this can directly lead to poorer health and adverse outcomes in people with severe mental health problems.
And self-stigma?
And self-stigma is another process where people internalise beliefs about themselves, which might then impact how far they're able to seek care when they need it or seek out relationships and so on. So self-stigma is an internalisation of the processes that are otherwise at play.
And finally, you say stigma operates at a research level due to the exclusion of those with severe mental health conditions from clinical trials. Is there a reason for that?
So yes, I mean, when clinical trials are operating, there's usually a set of inclusion or exclusion criteria, and very frequently people with severe mental health conditions will be excluded from those trials. So that then means that research is generated which might not be so applicable to those populations. There's lots of reasons for it. Some of it might be to do with when we're sort of doing drug trials, industry might want a sort of quicker pathway to regulation and so on. But what it actually leads to is a sort of scientific neglect for these populations. And we find that when we're trying to develop guidelines, for example, that relate to these groups in terms of clinical management, the evidence for people with severe mental illnesses might be lacking compared to other populations.
Thank you. Professor, you've also noted at paragraph 34 of your report that people with severe mental illnesses appear to have a greater risk of comorbidities, such as cardiovascular disease. But it's right to say there are some important differences about those between ethnic groups. Is that correct?
Yes.
And you also refer to the effects of social deprivation at paragraph 36, which you say is associated with reduced life expectancy. And you say that people with severe mental illnesses are more likely to experience this, for instance, because of high levels of unemployment.
Yes.
And lastly, at paragraph 37, you touch on the impact of the medications that are prescribed for the conditions. But it's right to say that whether or not they overall have an adverse or beneficial impact, it's not well understood.
No, it is understood. So many of the medications that are used to help people with severe mental health conditions are associated with some adverse effects around weight gain, a high risk of developing diabetes and so on. So they can have an impact in terms of physical health, but we know from studies that have been done that actually the same medications, when people are taking them, seem to be associated with improvements in mortality outcomes. So it's a sort of mixed and slightly complicated association. It might be that the medications are needed to help people stay well, but they're still associated with physical health problems that also need to be considered and managed.
Thank you. So, Professor, drawing all of that together, you've identified many reasons why people with severe mental illnesses are at risk of early death. But it's your evidence that these are all factors that were essentially pre-existing and they impacted on the death rates we've heard about prior to the pandemic.
Yes.
Thank you, Professor. I now want to turn to mortality figures post-pandemic and how people with severe mental illness were impacted. At paragraph 40 of your report, you've drawn on your own research, as I understand it, and also on the clinical practice research data link. Can you briefly describe what that is as a resource?
So the clinical practice research database, a data link, CPRD, is essentially a data set of general practice records across, and it's fairly representative of England. We use data from CPRD to look at levels of mortality in people with severe mental illnesses following a COVID-19 infection.
And I think you said, although that data doesn't cover Scotland and Wales and different parts of the UK, your view is that if you look at the pre-existing patterns of mortality, there's no reason to believe that this isn't UK-wide, even though that resource does not cover the whole of the UK.
Yes, exactly. And actually, in the study that we did do, we were able to look at Northern Ireland and I think it was 7 regions across England, and we looked for variation, and we didn't find any evidence of variation. So a higher risk of death following a COVID-19 infection in people with severe mental illnesses that was the same, irrespective of where they resided.
Thank you. And your conclusion, again, from that research at paragraph 40, is that across the 2 initial waves of the pandemic, people with schizophrenia and bipolar disorders were more likely to die following a COVID infection than the general population.
Yes.
I'm going to obviously deal with that in a bit more detail, but adjusting for other factors, you found a 53% higher risk, and we're talking about any cause, not just
Yes.
COVID, and that's across the UK. That's your conclusion.
It's across England and Northern Ireland, yes.
But you believe it should
Yes.
be consistent across the UK, given,
Yes.
in effect, the control you've done by looking at different regions and one in Northern Ireland.
Yes.
And at paragraph 43, you also look at this in a different way. You look at data from one UK trust, which you point out is one of Europe's largest, and you compare the deaths in a sample of people with a number of different severe mental health conditions, essentially alongside a control group. Is that the way I should understand that?
So yes, we looked at deaths during prior to the pandemic and then during the pandemic across 9 different diagnostic groups, and we compared their experiences to a reference data set that was collected prior to the pandemic.
And it's right to say, I'll come back to some of the specific conditions, but it's right to say that across the conditions, the severe mental health conditions that you analysed, there was a sharp rise in mortality following the outbreak of the pandemic for all of them. Is that correct?
Yes.
And again, we're looking now at all causes of death, not simply COVID-related deaths.
So we looked at all-cause mortality, and we also looked at COVID-19 deaths.
We'll come back to that. But this is your figure too. I'm not putting that up on a slide because it's an extremely intricate figure, but it's figure 2 in your report. But thank you very much for describing that. Would it be fair to say, or to summarise that as evidence of the gap widening, the gap you've already described in terms of mortality for people with severe mental illness during the pandemic? Would you say the gap widened?
Yes.
For at least some of these diagnoses?
Across the board, it was actually for all of the diagnoses. Of course, there are some issues with precision of estimates, which I can go on to talk about, but ultimately there was a similar pattern across each of the 9 conditions that we looked at.
Could you perhaps explain for which diagnoses we can be the most confident about that?
So I think the most striking rise in deaths was in people with intellectual disabilities. That was outside of the scope of the report, but it's worth noting that. And these were people who are under the care of secondary mental health services. We also noted a rise in people with dementia and schizophrenia spectrum disorders, also actually with affective disorders, substance use disorders and so on. So actually most of the conditions showed a stark rise following the onset of the pandemic.
And just finally, the point that you've made is illustrated another way at paragraph 43 through figures that show deaths in the second quarter of 2020 during the pandemic were significantly elevated compared to the same point in the previous year in this cohort. Is that correct?
Yes.
Thank you. Professor...
Can I interrupt? Can I just ask, going back to the point about those that suffer from dementia, as I understand, albeit you can get early onset dementia, the vast majority of people with dementia are likely to be over a certain age, and they were, of course, at high risk from the virus anyway because of their age.
Yes, that's true, yeah.
Moving on to COVID-specific deaths, that would be your figure 3, which is at paragraph 46 onwards. And we're still, as I understand it, we're looking at 2020 here. So moving on to excess deaths from COVID itself. The previous figure was all-cause mortality. This hones in on COVID itself. You've said that also was increased across all the conditions covered. And perhaps coming back to my lady's point, you highlight that dementia is one of the ones where it was much higher than the general population. Is that perhaps because of some of the features that my lady has pointed out, that they'd be at higher risk of the COVID pandemic? It's not simply the mental illnesses.
Well, I think just to come back to that point, so yes, there was a higher risk in the dementia group. These figures have also standardised by age, actually, I should say. So that should take into account differences by just being older. And so actually this should tell us what the deaths from COVID-19 were doing in that group, taking into account age and gender.
Thank you. And you've also identified, I think, schizophrenia and eating disorders in particular at paragraph 47 of your report, where deaths were much higher than in the general population.
Yes.
And are you able to help us with the reasons for that?
So I think there's potentially a range of reasons. As I've highlighted throughout the report, many of the factors that were a concern prior to the pandemic continued to be a concern during the pandemic. There were other factors that came into play. So what the figures show is that going into the pandemic, each of these conditions, people had a higher risk of death. And those deaths from other causes continued to be a concern during the pandemic. But then during the pandemic, there was an added extra risk from contracting COVID-19 and a heightened risk of death as well.
Thank you. Now, you mentioned in your evidence before that people with severe mental illness are also at increased risk of comorbidities and the behaviours affecting mortality. I don't need to take you to it, but at paragraph 104 and 103 and 104 of your report, you do confirm that if you look at it from the perspective of those with comorbidities, they were also more likely to die during the pandemic.
Yes.
And finally, on this, you told us earlier on that this group is at increased risk of suicide. Is it right, however, that there isn't any confirmed increase in suicides during the pandemic, as you say at paragraph 104?
We couldn't find any evidence to support that, but I think, as I've highlighted in that paragraph, having a severe mental illness like schizophrenia means that people are at an increased risk of suicide, just from a sort of clinical perspective. So I have no reason to believe that that would have changed during the pandemic, but we couldn't find any data that directly spoke.
You do say that you consider that that group would have been at increased risk during the pandemic of suicide. And we will be hearing, my lady, tomorrow from Mind about some of the services they offer to people who were experiencing suicidal ideation. And again, finally, Professor, is it right to say that the increased deaths are broadly in keeping with the international data on the same groups, as you say at paragraph 48?
Yes.
Thank you. We've already, you've already highlighted that although it was outside the scope of your report, it did seem to say earlier on in your report that those with learning disabilities were at very increased risk too.
Yes.
Thank you. Professor, I want to move on to the latter stages of the pandemic because I think that your studies were focused more at the earlier two waves, essentially. Now, dealing with vaccination, you've pointed out in your report that this group were prioritised for vaccination. You've pointed out that despite that, excess mortality continued to be a concern. And you note studies both in the UK and internationally that suggest that lower vaccine take-up might be a cause of that. At paragraph 51 of your report, you have noted that measures could be taken to improve vaccine uptake in this group. Could you just summarise your suggestions, please, from paragraph 51?
So I think it was a really good thing that Britain prioritised people with severe mental illnesses for vaccination. I think we were one of only a few countries across Europe to do that, and that was really important. But I think what we're starting to note is that despite that, and despite actually then reaching higher levels of vaccination in these groups, it was not as good as the general population. So in order to enhance vaccine uptake, and I think more research is needed to try and understand what we can do, but it could be that we can more proactively encourage vaccine uptake, which might be through health services, it might be through incentivising general practice to offer that as part of a health check. It could be through other sort of public health measures such as health education, health promotion, and so on. So I think lots more can be done, but we did manage to achieve reasonable levels of uptake initially for these groups, just down to having prioritised vaccination in the early stages of the pandemic.
Thank you. Moving on to a subject that you touch on at paragraphs 53 to 58 of your report, and you considered whether any particular effects on mortality were evident for those with severe mental illness from minority ethnic backgrounds and other protected characteristics. Is it fair to say that essentially there's insufficient data to enable you to reach any firm conclusions here?
So I think what I've stated in that bit of the report is that the gap in life expectancy that had been documented in white British people with severe mental illnesses had been demonstrated to a similar extent in ethnic minority groups prior to the pandemic. During the pandemic, many of the risks that we've already talked about were experienced to a similar extent amongst each of the ethnic minority groups where studies have been conducted. So there is a bit of evidence that seems to suggest that the higher excess risks from contracting COVID-19 and death was experienced to a similar extent across ethnic minority groups living with severe mental health conditions.
You've said that given pre-existing factors like stigma, these groups may well have faced an element of double jeopardy leading to higher death rates.
There has been a suggestion of that, yes.
But you can't put it really any higher than that, given the evidence base.
There hasn't been much work done, but of the work that has been done, there's a suggestion that there are similar trends definitely at play in ethnic minority groups living with severe mental health conditions.
Thank you, Professor. Drawing then together the evidence in relation on mortality, you've said there's pre-existing reasons for reduced mortality, including factors like stigma in all its forms.
Yes.
And it's your evidence that those pre-existing factors are likely to have persisted throughout the pandemic.
Yes.
And then there are also more pandemic-specific factors. Just touching on what we heard from Professor Osborne this morning, he explained the impact of availability of PPE and testing in inpatient settings was a factor. And I think you say, and you've highlighted it in your executive summary at paragraph 5, and you deal with it in more detail at paragraphs 99 and 100. You think that this issue will have contributed to higher risks of infection and mortality in this group?
Yes.
And just dealing with infection control in these settings, we've heard again from Professor Osborne about the challenges. For instance, close proximity when caregiving, patients not understanding distancing rules. Are these factors that make it particularly difficult to control infection or made it difficult to do that during the pandemic?
Yes, it would have done.
Now, just in terms of that and prioritisation of people with mental health illnesses in hospitals, would it be fair to say it's not surprising that people with physical conditions, like respiratory conditions, might be prioritised for PPE? But what you're saying is that there are particular features with those with severe mental illnesses that also needed to be prioritised or at least recognised.
Yes, exactly.
Is there, I think you link this to the idea of parity of esteem. I mean, have you got any, could you expand on why you think that the need for PPE in these settings wasn't fully appreciated in the way you've described?
So, as I've highlighted in my report, there was a study done looking at inpatient mental health services across London, which seemed to indicate that access to PPE and testing, actually for COVID-19, was quite delayed on those wards. It was a study of older people with severe mental health conditions. And the study essentially found that those delays led to people coming into the wards when they didn't have a COVID-19 infection, contracting the infection, and then being more likely to die. The authors of that study speculate that the levels of deaths as a result of contracting COVID-19 were higher for those who were admitted to those units. And I suppose the main kind of one of the bigger elements to sort of pick up, which I'd raised earlier, is around parity of esteem. So the authors suggest that because mental health services were given a lower parity of esteem compared with general medical services at this time of intense national pressure, it had an impact, which then led to these adverse effects in older people admitted to mental health units.
So that's one study. I think is it the Livingston
Yes.
study at paragraph 1999 of your
Yes,
report?
yeah.
And it's one study looking at a particular cohort of older adults.
Yes.
But it is across 5 trusts.
Yes. Across London, yeah.
Where that was found, and so they are suggesting that can be fitted into the idea of lack of parity of esteem
Yes.
and understanding of
Yes.
risks to this particular cohort.
Yes.
Thank you. You've also considered other pandemic factors. We've discussed them: lower vaccine uptake despite prioritisation of the group. And final question on this section, which you may or may not be able to answer. To what extent do you consider the primary drivers of excess mortality within these groups to be pandemic specific, and to what extent rooted in pre-existing structural inequalities that you've set out?
So I think it's a bit of both. I think that the pre-existing risk factors continued during the pandemic, but I also think that during the pandemic, other pressures such as reduced access to services, some of the stresses of that we all experienced during the pandemic, some of the issues around PPE and so on, had an impact too in terms of mortality during the pandemic. And of course, there's that study that you'd already raised, where we know that when people with severe mental illnesses are infected with COVID-19, certainly in the early stage of the pandemic, prior to vaccination rollout, they had a higher risk of death. So I think it's a bit of both, pandemic-related factors and the pre-existing risks which continued.
Thank you very much, Professor. I'm now going to move to the second part of your report, that's section 5 from paragraph 99, and this is about the changes in symptoms experienced by people with these illnesses. And you say at the outset that many of these studies are very limited in terms of their quality and generalisability. So it's fair to say that your findings here do have significant caveats, is that correct?
Yes.
So I will take you to what I understand to be the main points you have reached. Again, we've heard from Professor Osborne and from yourself that there is a reduction in people presenting or seeking care for severe mental illnesses. And he's described that as a treatment gap because just because they didn't present doesn't mean they didn't still have the symptoms. And he's also described people delaying seeking help and then presenting in a worse condition. It seems to me that you agree with that analysis essentially at paragraph 62 of your report.
Yes, I do.
And moving on to the issue of online care, similarly to Professor Osborne, you seem to say that it was welcomed by some, but some people found that it adversely impacted on their symptoms. Is that correct?
Yes.
And I think you also highlight those with severe mental conditions from minority ethnic groups.
Yes.
You talk about lack of or poor internet connection, insufficient computer equipment and skills, and loss of clinical face-to-face contact. Those are the sorts of issues that they experienced.
Yes.
Now, I'm going to, given what you've said about really the lack of evidence, take specific diagnoses in fairly short order. There are 2 or 3 where you've made quite a lot of detailed findings. And the first is people with schizophrenia, delusional disorders, and severe depressive and bipolar disorders. And this is from paragraph 63 onwards, section 4.1. Again, what you're saying is that there is a lack of data and it seems inconsistent findings on the impact on symptoms. Is it fair to say some studies didn't report deterioration and some did?
Yes.
And I'd just like to ask you about one study then that you've mentioned at paragraph 68 of your report. And you've said that it didn't cover those from the UK. It's an international study. But it says people with some of these conditions were more likely to report greater self-isolation, distress, anxiety, depression, and COVID-19 related stress. And it highlighted social isolation and loneliness during lockdowns and disruption to healthcare were cited in those studies as causes for deterioration.
Yes.
So I'd just like to put on screen a couple of the accounts are part of our Every Story Matters report on mental health and well-being, which are, of course, from the UK. The first is someone from England who describes that they had a schizoaffective disorder and that the lockdowns hit them hard, and describes specifically the limit to phone contact for a 2-year period. And they believe that this had a devastating impact on mental wellness, and felt abandoned. And then on the next page, we've got somebody from Wales who says, as somebody who lives with bipolar disorder, I am used to regular face-to-face sessions with a psychiatrist. This stopped, was replaced with 6 monthly calls for 5 minutes. I haven't had a medication review or face-to-face meeting since the end of 2019, and I've suffered with a major depressive episode in that time. No help was made available. So, Professor, do these sorts of issues reported to us chime with the sorts of issues that the international studies capture?
Yes, this absolutely resonates. And I think later on I go on to talk about some of the qualitative studies which have been done in this area, and they, and both of these quotes align with what those qualitative studies also report.
The study that you described suggests a number of strategies that might be used to mitigate this sort of impact, including frequent phone calls, home visits, or even exemptions to restrictions based on certain diagnoses. What's your view on that?
I think it's a balance of, and I understand it was a very difficult time in terms of needing to control the spread of the virus, but I think what a lot of the evidence seems to indicate is that people were really severely impacted in terms of their mental health through some of the measures that were taken. You raise the issue of, difficulties in accessing digital online consults. And we know from some of the evidence which we've reviewed that community centres, for example, helped people with severe mental health conditions to get online to have their clinical assessments. And so in some situations it may have been preferable to have supported that maybe earlier on in the pandemic, but I suppose it's that balance against needing to protect the population from the spread of the virus against the needs that people with severe mental health conditions may have had at that time.
Thank you very much. Can I turn now to eating disorders? And this is from paragraph 69 onwards in your report, section 4.2. You've said in summary that several systematic reviews suggest symptoms did get worse, but you have quite significant reservations about the quality of that evidence. Is that correct?
Yes.
And why is that?
I think for the reasons that we've already discussed, many of the studies didn't necessarily have data on people's mental health conditions prior to the pandemic. The longitudinal studies may have suffered with loss to follow-up. The way that the diagnosis was also made is a concern. However, of the studies that I have included in that section, I think it's broadly consistent with what we know, which is that there does seem to have been a decline for people with eating disorders in terms of their condition, and I think that's also consistent with what potentially Professor Osborne reported in terms of service use for people with eating disorders in the session this morning.
Yes, and in terms of the sorts of impact that we're talking about in terms of eating disorders, if I can just run through that list, it's at paragraph 70 of your report. What you're talking about is changes in routines, such as physical activity, which could lead to an overfocus on exercise. Is that one of the problems?
That was one of the issues raised in one of the studies, yeah.
And loss of control, changes with relationships with food. So for this particular group, that could mean difficulties getting hold of what might be classed as safe foods. Yeah. Distress from the media, including messaging about avoiding weight gain during the pandemic. Was that something that you saw in these studies?
Yeah.
And finally, reduced social support and disruption to healthcare provision, which we've touched on.
Yes.
Now, that was one of the issues that has also come up again in Every Story Matters, this issue of support. Is there a particular factor for people with eating disorders which is around monitoring their own weight, which the pandemic and the restrictions had an effect upon?
Well, again, it came out in one of the studies that we reviewed, and I think that's highlighted in paragraph 71. So people with eating disorders were reported in this study as having to monitor their own weight in order to inform remote clinical management. So I suppose that in itself can be distressing, but it also means that people might have been able to hide the fluctuations in their weight in a way that, had they been able to see clinicians face to face, might not have been the case.
Again, if I could get up on the screen something from the report, Every Story Matters. It's INQ 000659-895 at page 41. What is said there by a contributor from Scotland is that they found it easy to hide their eating disorder. Their family was shocked when they saw them for the first time due to the loss of weight, and not being able to have them checking up on them was really the big issue there. And then below that, there's something about struggling with mental health since the age of 11 from another contributor. And again, a description of the eating disorder worsening and going unnoticed because everybody was so stressed and busy. And there's a description of daily fights at dinner, depression worsening because of a lack of social connection, not seeing friends and family. And this person has said that they began to self-harm multiple times a day. Again, do these accounts chime with what you saw in the research, despite its limitations, about how eating disorders were impacted by the pandemic?
Yes.
Thank you. I want to turn now to obsessive compulsive disorder. Again, you highlight very limited research in the UK, but is it right, Professor, that outside the UK, studies suggest certain features would likely have impacted on symptomatology, such as overexposure to news, leading to fears of contamination and compulsive behaviour around cleaning and hand washing?
Yes.
Thank you. I don't have any more points. I think that's the only point that you make about that. Turning then to paragraph 78 of your report, people with neurodevelopmental disorders. Most of that evidence is out of scope, as you point out, as it's focused on children and their caregivers. But you do point out that there's one study that suggests increased depressive and anxiety symptoms in adults with autism. And as I understand it, the distress is particularly due to disruption in normal routines, such as shopping and lack of clarity around lockdown. Is that something that would cause particular distress, potentially?
Yes, as reported in this study.
Though conversely, the lack of stimuli and social overload and increased sense of solidarity were reported by some as positives, I understand.
Yes.
Professor, finally, you've touched in your report on some other conditions like panic disorders, post-traumatic stress and personality disorders. But it's right to say that there's too little evidence on that to base any firm conclusions.
Yes.
I want to move on now to some observations you've made at paragraph 83, 88 and 91 about evidence of disproportionate impact in terms of a deterioration in symptoms on people from minority ethnic groups. And you refer at paragraph 88 to the Hildesley paper, and I think you had some involvement in that paper, is that correct?
Yes, that's a paper from my group.
Thank you. So this was a large population-level study, but it's right to say it was focused on secondary mental health service users in one geographical area, is that correct?
Yes.
And it found that while overall admissions to mental health units dropped, a larger proportion of admissions were compulsory, so detentions essentially.
Yes.
We've already heard this morning from Professor Osborne about what a compulsory or involuntary admission is, and essentially he's confirmed it means people being detained justified because they require treatment under legislative powers, so not on a voluntary basis. Do you agree broadly with that description? And he's also described how some people were presenting later, essentially in crisis. Does that accord with your understanding of this increase during the pandemic?
Yes.
And in this particular study, Professor Osborne referred to another one, but you've referred to Black Caribbean service users being 1.54 times more likely to be compulsorily admitted in that study during the first lockdown. Is that correct?
Yes, first and second lockdown in 2020.
And the second lockdown, it was elevated for both Black Caribbean and Black African groups. Is that
Yes.
right? And again, it's right to say that both Black Caribbean and Black African groups were already known to be more likely to be compulsorily detained. Is that correct?
Yes.
But you've suggested that these findings may suggest that the pandemic has magnified pre-existing inequalities. Is that correct?
Yes.
Now, Professor, we've heard a lot of evidence on this theme, but what do you mean by it when you say it magnified pre-existing inequalities?
So what I mean is that, as you've highlighted, we knew about these inequalities prior to the pandemic. There'd been a Modernising the Mental Health Act review in 2018 that picked up exactly these issues. And what I mean by magnified is that these issues continued to be a concern during the pandemic, but got worse for some of those groups that had been highlighted prior to the pandemic due to a range of factors. So in effect, amplified, or the same problems continued with the addition of inequalities being exacerbated through the pandemic.
In terms of learning, Professor, one of the issues you're highlighting is a rise in crisis-driven detentions. Are there any practical safeguards or interventions that could be considered to prevent this in a future pandemic or civil emergency?
So there are moves at the moment, really arising from the Modernising Mental Health Act review, to develop more to improve services in terms of access to care. So there's a patient care and race equality framework, which is being currently rolled out across England. And so I think some of those sorts of interventions to try and make mental health care more accessible for minoritised groups may start to shift the dial a bit.
Thank you, Professor. Now, you mentioned earlier on that you've considered some qualitative studies that's involving more in-depth individual accounts, and you talk about those at paragraph 93 onwards. And they did specifically consider the experiences of those with severe mental illnesses from minority ethnic groups. Is that and other minority groups? Is that correct?
Yes.
And you say that they are more in-depth, but is it fair to say that there are more limits in terms of generalisability?
Yes.
However, you have noted here, and again later in your report, at 110, that when you look at those accounts, many of those interviewed did complain of stigma and discrimination in the way they were treated. Is that correct?
Yes.
That's something you've highlighted about their experiences in your executive summary as well as a significant finding.
Yes.
Despite the fact it's a qualitative source.
Yeah.
Overall, though, as against that, again, from your executive summary, you say that there is a dearth of data relating to the impacts in people with severe mental illness and other protected characteristics. And you say that was a major concern to you. Can you expand on why?
Because, it's a major concern because we may assume that things might be worse if we were able to collect that data, but we're unable to make any assessment because we don't have the information to allow us to understand what is happening for people from racially minoritized backgrounds or who have other protected characteristics living with severe mental health problems.
And is it right to say, I think you might say this somewhere in your report, those missing from the data, they were possibly the people in the worst situations?
Quite.
And we can't learn without knowing about what happened?
Yes.
One group you do mention in the report is migrant groups, refugees and asylum seekers. Are you aware of any data recording the impact of the pandemic on the mental health of such groups who also have severe mental illnesses?
I didn't come across any studies that had looked specifically at people with severe mental illnesses.
So, Professor, in conclusion to your report, at paragraph 110, you say that the pandemic exposed and exacerbated pre-existing inequalities. But it's fair to say when it comes to the impact on ethnic and other minorities, that conclusion has been based on quite limited data.
Yes.
However, is it also right to say that that in itself is part of what you've already described to us as part of stigma at the research level?
Yes.
Thank you. Leading on to that and some other points about it, you say that concerns about data collection have been long-standing. Can you give us an idea from your recollection how long-standing? When were these concerns first raised, to your recollection?
So there's been fairly long-standing concerns around the quality of data for ethnicity and other protected characteristics, even prior to the pandemic. So, as an example, the last nationally representative survey of mental health in ethnic minority groups was done a few decades ago. So these are long-standing issues. There's been concerns around the quality of data collected for ethnicity and, again, other protected characteristics in health records as well. There have been moves to try and improve things, and I think since the pandemic, some of those measures are better collected, but there has been, across the field, concerns that we don't really collect the information to be able to understand how mental health and other associations might play out for some of these groups.
And are there any specific reasons why this hasn't been collected over this long period of time?
So for health records, those are records that are collected routinely in the process of delivering care. So they need concerted effort to ensure that data relating to ethnicity and other protected characteristics are indeed captured. So that requires potentially additional funding. It involves working with the people that are delivering care to collect that sort of data. And so to a certain extent, although there have been moves to try and improve things, it might be that more needs to be done in order to support people to collect that data on people in contact with care. In terms of the national surveys, there had been moves to boost one of the more recent mental health surveys by ethnicity, but there were some challenges with recruiting people to those studies, and in the end it was decided that it would not be feasible to continue to collect that data on ethnic minority people and their mental health.
Thank you very much. Professor, at section 5 of your report, you draw together factors that impacted on outcomes, both in terms of mortality rates and symptoms, so both parts of your report. I just want to pick up on a few points, and I'm not going to focus on ones we've discussed before or that Professor Osborne's already dealt with. At paragraph 106 of your report, you touch on pre-existing factors. We've heard a lot about these in various ways: financial insecurity, unemployment, alcohol and substance use, and intimate partner violence were known to increase in frequency during the pandemic. And you say that may have played a role in exacerbating mental disorders for some groups. And I just wanted to ask you about one of those, and one of the comments you make. In terms of intimate partner violence, you may or may not know that the definition under the Domestic Abuse Act 2021 encompasses physical, sexual, psychological, economic and controlling behaviours. Does your comment about that extend to all of those different sorts of behaviours?
I wasn't aware of that definition, so I'm not sure, to be honest.
That's fine.
The sentence relates to a study that I've referenced there by Chandan and colleagues in the British Journal of Psychiatry, which essentially found an association between people experiencing intimate partner violence and then their subsequent risk of developing mental health conditions.
Thank you. And at paragraph 107 of your report, you've highlighted the importance of social support from community organisations such as mental health charities, places of worship or support networks. As a general point, would you agree that factors such as social isolation, loss of routine and disrupted support impacted specifically on the people with severe mental illnesses?
Yes.
Thank you. And you've also said that people with these illnesses who had access to networks were protected to some degree from a deterioration in mental health. That's also drawn from your research.
Yes.
You've touched on one issue in your report at paragraph 82. I don't need you to go back to it, but it's on the experience of those living with within mental health residential settings, and on the same theme, the impact of a lack of access to the usual networks and routines. Are you aware of anything that would explain to us the impact from visiting restrictions on the mental health of psychiatric inpatients?
I didn't come across any studies which specifically explored that from the perspective of service users. There was one study that we identified which looked at challenges that mental health service providers identified during the early phase of the pandemic, and that was raised as a concern.
Thank you. Professor, leading to the end of my question, summarising your overall conclusion in lessons learned, which is from paragraphs 113 onwards in your report in section 6, essentially you're saying that the pandemic has deepened mental health challenges in this group, and that's beyond mortality.
Yes.
And you've set out a number of lessons learned at the end of your report, which could inform future pandemic responses.
Yep.
I won't go through all of them, but is it correct to say that some of them are to the effect that the pandemic has reinforced the need to tackle pre-existing inequalities, such as in relation to reduced life expectancy?
Yes.
Are you essentially saying that without taking on board these lessons now, you can't be confident that issues such as excess mortality would not be replicated in the event of another pandemic or civil emergency?
Yes.
We've already established that one of your main concerns is lack of data, meaning some impacts are not fully understood. In terms of COVID-specific lessons, we've also discussed the importance of prioritisation for vaccination and improving vaccine take-up. That's one of the big lessons, I think, from your report. You also highlight the importance of access to PPE, testing and training for those working with people with severe mental illnesses. Is that right?
Yes.
And that's given the particular challenges of infection control that we've discussed?
Yes.
Thank you, Professor. In relation to non-pharmaceutical interventions like lockdown, you, like Professor Osborne, have noted the issue of delayed presentation, and you suggest that community organisations can play an important role in mitigating the effects of social isolation and digital exclusion. That seemed to be another of your main lessons learned.
Yes.
And finally, you suggest that experts on mental health and neurodevelopmental conditions, including people with lived experience, could help with designing interventions, guidelines and public messaging.
Yes.
Is there anything else specific to the pandemic that you would like to highlight as a lesson learned?
No, I think that's covered all of it.
Professor, those are all my questions, but there may be some more for you.
Thank you, Ms. Rahman. Ms. Virarotny, go over that way.
Good afternoon, Professor. I ask questions on behalf of the Migrants' Rights Consortium. One of our key concerns is the lack of understanding of and planning for migrant groups excluded from essential services. Now, you've already been asked, quite helpfully, some questions around data collection specifically in relation to migrant groups, and you've already said that there hasn't been any as far as you're concerned or you're aware of. Your report, you've just been taken to part 6, which is about lessons learned. And one of the points at para 119, you refer to the need for improved data collection for vulnerable groups, including those with protected characteristics. The bit I wanted to ask you about now is towards the end of paragraph 119, where you talk about innovative data collection strategies. Do you recall that?
Yes.
And really, the simple question, firstly, is to what extent those innovative strategies, which you say are now being implemented with regard to migrant groups, including refugees and asylum seekers?
So there have been developments since the pandemic in terms of large-scale linked data, which brings together electronic health records with other types of administrative data. In terms of migration, that would require bringing together data sets like Census 2021, which does ask a question about country of birth and years residing in the UK, linked to health records, for example. I'm aware that linkage has been done. It's not yet readily available outside of the ONS. So those data sets are being curated, they're being developed. Whether or not they could be used in a future pandemic would need to be seen, because they're sort of static data linkages, so which wouldn't necessarily tell us about a future event, but nonetheless bring in data on migration status and have the ability to inform future research using those sorts of data sources.
So if I'm right, what I understand you've just said is that those data linkages are important to understand the situation as it is now, let's say, and that would inform any future pandemic, should there be one.
Yes, it could be used, yeah.
Right. And just finally then, just to wrap that up, I've understood you to be saying that it's a major concern of yours that there should be improved data collection in this group of those with severe mental illness in particular, but it must include all vulnerable and marginalised groups, including the migrant groups that I've identified, in order to better understand and hopefully to rectify health inequalities now and for future pandemics. Is that correct?
Yes.
Right. Thank you very much.
Thank you very much. Ms Davis, who's that way?
Professor Dashmushi, can you hear and see me all right?
Yes.
My name is Liz Davis and I ask questions on behalf of the Domestic Abuse Group, which is, a group of 3 organisations in the violence against women and girls sector. And you were asked by Ms Rahman a few minutes ago about paragraph 106 of your report. You don't necessarily need to look at it, but you record that intimate partner violence was known to increase in frequency during the pandemic, and that may have played a role in exacerbating mental disorders for some groups. You put that in with a number of other factors, but that's one of the factors. It's right and fairly obvious, isn't it, that being subject to domestic violence can impact a person's mental health such that severe and enduring mental illness can develop?
Yes.
Yes. And therefore, one could say that the rise in domestic abuse that happened during the pandemic may be one of the contributing factors to the increased severe and enduring mental illnesses during the pandemic. Or is that too simplistic?
That might be a little bit too. So I think trauma, including intimate partner violence, has been associated with an increased risk of developing some mental health conditions. But I think as a single factor on its own, leading to a rise in mental health problems is perhaps a little bit too simplistic, and there were probably other contributors that have contributed to a rise, if indeed there has been a rise since the pandemic.
And can I just ask you about a number of factors that might contribute to a decrease in mental health for somebody who is a victim survivor of domestic abuse in the context of the pandemic? One might be difficulties in securing support during lockdown. That might contribute to an increase in mental ill health.
Yes.
Yes. Another might be the difficulties in finding somewhere safe to stay during lockdown as compared to pre-pandemic, non-pandemic times. Again, that might be a contributing factor.
Yes.
And another might be where the pandemic produced new patterns of abuse, and specifically abuse around coercive control. For example, we have evidence that perpetrators of domestic abuse were limiting victims' access to technology, exploiting the fear of the virus, and even deliberately infecting their victims at times. Any of those would potentially be a contributing factor to an increase in severe and enduring mental illness.
These can all potentially contribute to a decline in somebody's mental health.
Thank you very much. I'm grateful. I'm grateful, my lady.
Thank you, Ms Davis. That completes the questions we have for you, Professor. Thank you very much indeed for your help. You haven't got too far to go, have you, to go?
No.
I thought we'd acquired you from somewhere relatively local. So thank you very much for your written report, obviously, and for coming along today to help us. Very grateful.
Thank you.
And I shall return at 10 o'clock tomorrow.